All right, so let's get started here. Welcome, everyone. Hello, my name is Rhonda Fisher, and I am the clinical program lead for team training for the AHA team training program. So, welcome to our May webinar on Leading the Way, Healthcare Organizations' Commitment to Workforce Well-Being. We're super excited about this webinar today. Lots of you joining us. We know this is still a topic that is really on your minds out there. So, really glad you could join us. But before I hand it off to our speaker today, I'm going to go over some rules of engagement and just a few announcements. You can access audio by listening in through your computer speakers or through your phone. If you're having issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio. Please note that you will be in a listen-only mode throughout the presentation today. I will moderate a Q&A session at the end with our speakers. So if you have a question, please chat them in throughout the presentation. If it's a technical or logistical type question, we'll answer that right away in the moment. But if it's for our speaker, we'll save that to the end. Finally, please note that this presentation is being recorded, and we will notify all registrants when the recording is up on our website so you can listen again. All right, let's talk about CE. We're happy to offer free CEs for our webinars, but there are a few steps you've got to go through. So in order to claim your CE credits, you need to create a Duke OneLink account. That's a one-time only setup. So if you've done it before, you're A-OK. But if not, my colleague Kara has chatted in those instructions. And you can also refer to the email that was sent to you this morning with the attachment. So following the webinar today, you're going to text the code you see on your screen, SAXKAW. You'll text that to the number that you see on the screen. Don't worry if you don't get it down right now, we'll pop it up and share it again at the end too. So you won't miss out on your CE. All right, let's talk about a few upcoming team training events. We have all kinds of our in-person master trainer courses coming up. Hooray, hooray. The next one next week, New Orleans. So if you're ready to fly by the seat of your pants, hop on a plane, come join us in New Orleans next week. Otherwise, there'll be another course in July, one in Chicago at the AHA Team Training headquarters in August. We're super excited about that. And then you'll see some fall dates there as well. So would love to have you join us. There's nothing like being in person, except for our virtual master trainer course with AHA Team Training. They are the best in the biz for doing virtual education. So if you can't travel, that's a fantastic option. That will be coming again this fall. Our webinars, this is our last one here for a few months. We'll be resuming in August of 2025. So make sure that you check our website for updates. You can access more information and registration links on the slide. Nope, sorry, that was last month. Never mind. See us in August. All right. So lastly, if you're looking for a more customized training solution, we offer on-site trainings where we come to your organization to deliver anything from just a 2-day custom Team Steps Master Trainer course to a comprehensive training program that spans multiple on-site trainings and virtual coaching so we can truly support your Team Steps implementation, helping you develop your internal capacity, fostering ownership, and most importantly, sustainability. So hit us up if that's something you're interested in. We'd love to talk to you. You can see how to get in touch with us towards the end of our time together. All right, with that, I am going to turn the presentation over to today's presenter. Welcome, Dr. Jonathan Ripp. He is the Dean for Wellbeing and Resilience and the Chief Wellness Officer at the Icahn School of Medicine at Mount Sinai. Super excited to have you here today, Jonathan. Take it away.
Well, thank you so much, and it's really a pleasure to be with you all and have this time to speak about a topic that is of so much importance to me and has been the basis of my career. As you mentioned, I am the Dean for Wellbeing and Resilience and Chief Wellness Officer at the Icahn School of Medicine in New York City at Mount Sinai. And I've been engaged in this work for about 2 decades. I got involved really more back in the time when there was not a lot of organizational efforts to address this, or institutional efforts, really. It was before any kind of regulatory attention. I was interested in the impacts of training on trainees, and got started really from a research perspective, and began studying the impact of the experience of going through training on residents. And from there, I've kind of followed the momentum that so many of us have seen, that we've seen, really paying tremendous attention to the issue of the well-being, not only, of course, of doctors in training, but of practicing physicians, and now really extending across the health professions. As such, there's been increasing attention to how organizations can address the issues of well-being. There's been recognition of why it's so important. And so I've had the fortune of, in many ways, being in the right place at the right time, being someone who started looking and studying at a topic before it was becoming so prominent and so present in the literature, and so was able to develop increasing administrative responsibilities, and have now been involved in national efforts as well. So with that background, I'm going to be speaking to you today about how healthcare organizations, hospitals, and healthcare systems can commit to healthcare workforce well-being, and to do so really at the level of the system. So how do we create systems that healthcare workers are working in that enable them to thrive? And what are sort of the interventions or tools that can promote that? So I'm going to speak a fair bit about how to promote the culture through well-being centered leadership and communications, and talk about how we can use novel efficiency tools to do that. I'll speak a little bit about ways in which increasingly we're thinking about how healthcare organizations should be held accountable for addressing the well-being of the workforce, and then talk a bit about who's in this space nationally. There's professional societies and organizations, including the AHA, that are playing an important role, and I'll speak to that as well. So, for many of you, I'm sure this is an issue that you're thinking about, that has been spoken about and is not new. Certainly, the attention to healthcare workforce well-being has grown over the years. And there have been a few inflection points, I would say. A number of high-profile physician suicides have been, spoken about, written about, and that certainly drew a lot of attention to this issue. There have been certainly the moral imperative that has been described through the literature, as the growth of the literature has demonstrated how much burnout and mental health, mental illness there is in healthcare professionals. This here is a picture some of you may have seen or recall. It's a trauma room emergency medicine physician who had just lost an adolescent who came in a motor vehicle accident, and it's the picture of someone who's suffering alone, right? Who he leaves, he goes out to the parking lot and breaks down. And I look at this picture and I think of times in my career when I've had experiences with the patients that I care for. And I should mention I'm a practicing general internist. And so, I think for all of us in practice, we can really sympathize with this picture. And so there's the moral imperative to address a large group of people, of healthcare workers who are experiencing levels of distress at various times in their career. Certainly, there's been a growing business case. It's pretty important for the healthy functioning of healthcare systems, from a financial perspective, to address the well-being of the workforce. And there's been a number of publications describing the financial impacts of not paying attention to this. And certainly, the regulatory environment has grown, starting probably with the ACGME back in 2017, but increasingly additional groups are paying attention to well-being, and the regulatory space is increasing its attention towards it. Many of you are probably familiar with data such as these. This is a study a couple of years ago from a cohort that's been of physicians that has been followed over time. And it's a very large cohort. Almost 100,000 physicians are queried with a survey that uses a standardized measure of burnout and compares that to the national population. And consistently, physicians have higher levels of burnout. Admittedly, there's a low response rate to this survey in the 6 to 8% range over periods of time, but still that accounts for many thousands of responses. Obviously, there was a bump in COVID, and this group it hasn't. I haven't seen their follow-up study as of yet with more recent data, but the prevalence that bumped up during COVID has come down, but still remains fairly high and above the national population. Um, we learned about this during COVID that the impact of burnout and how that took hold during COVID led to an increase in intentions to leave the profession, right? We talked about the Great Resignation. I'm sure many of you read papers like the one here about why healthcare workers were quitting during COVID. And we've seen some improvements since we've come out of that, but certainly there was a lot of concern and remains concern that we are losing healthcare workers on account of the conditions of the workplace and the burnout they experience. And in the midst of COVID, 1 in 5 doctors, 2 in 5 nurses indicated an intention to leave their jobs over the next 2 years, and that correlated with reporting that they were completing surveys that indicated they were burnt out, or some of these other characteristics here, the anxiety, the workload. But what's interesting, and what will lead into what I want to speak to you about, is that if you felt valued by your organization, by your leadership, that was protective. It was protective for a desire to leave your profession. So that's really important for those of you that are leaders. Your ability to enable the people that are reporting to you to feel valued is not only going to be protective for occupational well-being and mental health outcomes, but it's going to increase their likelihood to want to stay at the organization. All right, so it's important to say a word about how we organize our approach to well-being, because it really is such a broad construct that has many drivers that impact it. I'm sure some of you have seen these various models, whether it's from the National Academy of Medicine, the Stanford model, which is a simplified version, the Institute for Healthcare Improvement. There's many different ways to think about it, but almost all of these models break down the drivers into system level drivers and individual level drivers. And so, everyone's going to always bring their individual characteristics to the workplace, and that's going to influence how they respond to the work environment. But the work environment itself is going to have a huge impact. And certainly, I think there's data to show that healthcare workers are a very resilient group of individuals. I mean, when you think about the training and what's involved to get to the point where you are a practicing healthcare professional, whether it be doctor, nurse, or otherwise, you've probably been through a lot. You've probably a pretty resilient individual. And so a lot of what we're seeing and what we believe to be the cause of these negative well-being outcomes has to do with the system within which these pretty resilient people are working. And that's typically broken down into, when we think about the system, cultural factors and workplace efficiency factors. This is the model that we created at Mount Sinai, which we adapted from some of the other models. And we decided early on, I've been in my current position for about 7.5 years. We decided early on that it was worth myself and my team, it was worth taking time to come up with a model that matched our own organization and what some of our priorities and drivers were. And you'll notice that it looks pretty similar to the drivers that are in the Stanford model. We added a cog here that focuses on mental health as well. We felt it was important to highlight that. And you see that it's not these. Some of these are bigger than others. We really place a focus on those system level drivers, the culture and efficiency drivers. that we think are more impactful on the outcomes of fulfillment and meaning in work. And of course, our mission statement is really intended to capture that by showing that what we want to do is advance a culture that enables you to do your best work in a place where you feel valued. That's the focus on efficiency and culture. So there's many ways to think about interventions at both the individual and system level. As I mentioned, our approach has been on the system level, and certainly there's ways to increase efficiencies, whether it's practice models or the use of electronic healthcare, electronic health records, and clerical work reduction, which can involve schedules and work hours and control over the space. Today, I'm going to talk about interventions that can help promote well-being centered leadership and communications primarily, with a little bit of a touch on some of the efficiency efforts. But we know that these cultural domains have a big impact. So what is well-being centered leadership? This is from a paper from Shanafelt that kind of captures the ideas. And at the very core of this, it's not rocket science. It's about caring for people, caring about people always. That's the foundation of wellness-centered leadership. And when you talk to some of these visionary leaders who've turned organizations around, and not just in healthcare, they always emphasize that their job is to take care of their people, and that there's nothing more important. There's no greater resource within an organization. And I believe this extends beyond healthcare. In fact, some industries outside of healthcare have championed this work and have recognized this work long before we have. But really, if you can enable your people to feel cared for and supported, then that's gonna be have the greatest impact on your organization. The model of well-being centered leadership focuses on the idea that this has to do with relationships between individuals, and a big focus on teamwork. Certainly in healthcare, that's critical. And at the pinnacle of all this, if you can accomplish that, you're going to inspire people to change. You're going to inspire your folks to come in and want to continuously improve the organization that they work for, and that bears out in the data that I'll share with you. Certainly, we believe that leadership fits in the culture domain, and so that fits nicely for our model. And we saw the impact through a lot of our studies. Certainly during COVID, in April of 2020, when New York City was the global epicenter of the pandemic, we had the opportunity to conduct a survey. We sent our survey to nurses and doctors, residents, fellows, nurse practitioners, PAs, and so forth. And just about 56% of just over 6,000 people responded to this in the midst of the pandemic. And what we found was that 39% of those individuals screened positive for depression, anxiety, or PTSD, one of those three mental health outcomes, which was obviously pretty concerning. It was we did anticipate that we would see a lot of mental health outcomes such as these at that point in time. And interestingly, as it relates to what I'm speaking to you about today, if you felt valued and supported at work, if you felt valued and supported by your organization, that was protective for all of these outcomes. And it led to lower odds of depression, anxiety, and PTSD. So it's important in non-crisis periods. It may be even more important during crisis periods. And arguably, I've heard a lot of people speak to the current context that healthcare is operating in, really across the country, as a crisis period. There's many headwinds that healthcare is facing in the current time. So one could think about the current period being a period of crisis. And so, more than ever, it's a time for leadership. And that's why what I'm sharing with you, I believe, is so important and relevant today. Why does strong leadership matter? Well, beyond, kind of what you might think of as being intuitively why it matters, there's good reason, there's good data to support that strong leadership, which can be measured, and I'll get to that in a moment, leads to improved team engagement, improved quality of care, productivity, patient satisfaction, all the things that are critically important to the healthy operations of healthcare systems. It leads to less turnover, and basically better performance and results. You can measure this. The Mayo Leadership Index is a validated instrument, survey-based tool that you can ask individuals to rate their most immediate supervisor on these behaviors, these leadership behaviors. And I like to think about this as it's really kindergarten stuff, right? It's treat people the way you want to be treated, right? Some of this relates to physicians and kind of professional development priorities. So, and other healthcare professionals. So, whether your supervisor holds career development conversations with you, or is providing you feedback on your performance, that's, specific, I think, to those that really want to develop their professional skills. But then it's basic stuff, right? Are you empowered to do your job? Are you encouraged to suggest ideas for improvement? Are you recognized for a job well done? This is a basic human need. People just want to be recognized for a job well done. We find this time and again. When in uncertain times, it's critically important that you're kept informed about changes that taking place, right? Uncertainty drives anxiety. So the extent that leaders can keep you informed will make a huge difference. And you can measure these behaviors in one variation of this using a 12-dimension variation of that instrument that generated a score. You could see that 1 point difference on a 45-point scale led to a 9% increase in professional satisfaction, 3% decrease in burnout. So the more you demonstrate these behaviors as measured on this scale, the better off your people are going to be. And this is a bit of a busy slide, but it captures a lot of data that we at Mount Sinai have measured through our research team in a number of papers over the years. We found that during COVID, in addition to what I shared with you about some of those mental health outcomes, the occupational well-being outcome of burnout persisted during multiple points of time during the pandemic, and was more common in those who felt less valued by their supervisors, and as I mentioned earlier, that was also seen with these mental health outcomes like depression, anxiety, and PTSD. We saw this in the nursing cohort as well as the physician cohort. Feeling less valued by hospital leadership was associated with more burnout in nurses, and even suicidal ideation, lower perceived leadership support was associated with a greater risk of suicidal ideation. So really, leadership, if you're able to demonstrate supportive leadership, it can be enormously impactful, particularly in crisis periods. So when it comes to being a leader that exemplifies behaviors that are associated with the well-being of others, it's important to, follow that mantra that you always hear on a plane, you put your oxygen mask on first before that of others. So it's critical that leaders role model taking care of themselves. And there's many ways to do this. But certainly it can be, acknowledging, which may not be easy for all leaders, but we know that demonstrating vulnerability is associated with increased psychological safety that leaders can enable. And so when leaders indicate, I have a therapist, or I was treated for depression, or it's really when you're open about that decreases stigma and encourages people to care for themselves. Certainly, we know this from the data about credentialing and licensing language, and if there's questions that are deemed to be intrusive, the kinds of questions that the Dr. Lorna Breen Heroes Foundation is advocating to remove from licensure and credentialing applications, that those questions lead to a decrease in or reluctance for physicians to seek mental health care. So you could ask a question on a licensing or credentialing application like, are you currently impaired from a mental health condition? Which is probably what you want to know. You just want to know whether someone is impaired before you're credentialing them. But some of these intrusive questions say things like, have you ever been treated for a mental health condition? And what does it really matter if you were, treated effectively for depression 10 years ago? Why should that be something that you're asked about? And so we know that those questions can have an impact. So another important way that leaders can help others is by working on those languages. We know from a study of of a few thousand healthcare executives that burnout is present in our leaders as well, a third in this study. And so, it's pretty important that our leaders are taking care of themselves. And perhaps some are coming to mind when you hear this data that perhaps our leaders are burnt out, and that's obviously going to have impact on the people that they lead. Sometimes the best way you can support a leader themselves and enable that leader to be more effective is to provide them the tools for taking care of their own people who might be in distress. Sometimes the most stressful thing for a leader to do is know that one of their own reports, one of their people is in crisis. And so having some tools like this one that we created for our leaders to understand when, the way in which their own people are in distress, by having this sort of stress continuum model that they can have some basic tools to try to assess how their people are doing and refer those people to receive help or inquire about whether they need help and then refer them. Those tools can actually lower the temperature of the stress that the leader themselves, is experiencing. So supporting our leaders is a way to enable our leaders to demonstrate more well-being centered leadership behaviors. All right, shifting gears a little bit, I want to talk about how communications fits in all this. Now, certainly leaders can be those who deliver messaging within a healthcare system, but messages come from a variety of locations. And here too, the way in which communications occur in an organization can really make the difference in terms of the culture and the way people feel supported and valued. We learned this during COVID when we asked healthcare professionals what their needs were and what was driving anxiety, and they said basically five main things. They wanted to be heard, protected, prepared, supported, and cared for. That's what healthcare professionals requested from their organizations during the COVID pandemic. And it really gets to this modified Maslow's hierarchy, right? At the very base, we have this basic need to be cared for and to feel safe. That's where things have to start. And so communications really are important in terms of enabling people to feel cared for. And I would say that's the basis of a well-being focused communication strategy. And really, well-being work requires an element of marketing and marketing strategy. So when organizations are committing to the well-being of the workforce, it requires a strategic effort, and one in which, if you think about the goal of an external marketing strategy, well, it's to sell a product. The goal of an internal marketing strategy is to promote engagement and well-being. And I believe the way to do that is through a simple message, which is that we care about you. If you're able to effectively market that message internally, and of course you need to mean it and demonstrate it, but if you're able to market that, I feel that our people will feel valued and cared for, and that's going to promote a culture of well-being. We certainly see this from some of our data around intention to leave. And so this on the left side of your screen is the relevant importance of factors that contribute to an individual's intention to leave an organization. These are from our surveys of our faculty physicians at Mount Sinai. And what we found is that a positive workplace culture was the most important, and the leadership behaviors was the second. And so leaders that keep faculty informed on important changes had a decreased when individuals indicated that their leaders kept them informed on important changes, they were less likely to indicate an intention to leave their organization. So that informed piece has to do with communications. So, as I said, the purpose of a well-being communication strategy is to enable people to feel cared for. And how do you do that? By addressing informational needs, reaching the intended audience, which is a challenge of any communication strategy. You can send emails, but are people going to read them? So it's important to think about that. Provide content related to organizational support. So if you want people to feel cared for, you want to give them information about how they're going to be supported, and use a tone that engenders a sense of caring. And so the sub goals are to enhance the reach, to deliver the right content, and use an effective tone. Examples of how that might work. Well, to enhance the reach, ask people how they prefer to be communicated with. You could do this through surveys or focus groups. Make sure you're delivering the right content. Again, you can identify individuals that can represent cohorts within your organizations about whether the information that they received in the communication meets their needs, and if not, you can adapt. So really taking like a continuous improvement focus to the communications to continually try to get the information right to match the information needs. And then modulate the tone. I always say this requires a committee because I might think I'm sending something out with a perfectly worded, beautifully cared for tone, but I might show it to some other people and they say, well, you could change a few words here and there to make it feel more supportive. So it's always good to have a group that can work with you on that. All right, so let me see if this will work. I'm going to play this video.
Attention! Happy Doctor's Day. Please proceed to receive your Doctor's Day gift. Hi, I'm here for my Doctor's Day gift. Okay, great. What's your name? It's Bill. And what's your last name, Bill? Bill. Your last name's Bill? Yeah, it's Bill. Okay, Dr. Bill. Here's your ticket. Step over to the next table and a hospital administrator will give you your gift. Hi. Ticket? Here you go. Okay, great. Thank you. You're welcome. And back to work. Wait, that's it? Happy Doctor's Day. Now, please move aside. We need to keep the line moving. Can I get another thank you? I'm sorry. It wouldn't be fair to other people that only got one thank you. Attention.
So hopefully that was gave you a nice little chuckle there. I think the point that I want to convey is that communications clearly require words and are the basis of the message that we are delivering. But words alone are not necessarily going to do it. So you want to tie your words with actions. If you're going to ask people about how you can improve the workspace, and I put on here some of the models that those of you in the quality space are, I'm sure, familiar with: the PDSA cycle, continuous improvement, here the quadruple aim, which of course includes staff experience. That you want to create a mechanism whereby you have bidirectional communication. You're delivering a message you care, but you're also asking about how things can be better and then acting on the information you get. So, and that requires structure, and that requires integrating well-being into quality processes and leveraging quality continuous improvement processes to do so. But it's really important. What you'll find, and this is a model that the AMA has championed, is that a lot of times leaders are worried about asking how can things be better, because they think they're going to get a laundry list of items that they can't do anything about. And they will get some items that are that they can't. Someone's going to say, "Can you double my salary?" And they're or they're going to say, "Can you give me another team member tomorrow to help me with the volume of the work," and so forth. And some of the things they're not going to be able to act on, but almost certainly you're going to get items that you can act on. And so this is the listen, sort, empower. You ask for information, you listen to what people say, you sort them by impact and feasibility. So some of you might be familiar with an impact feasibility plot. Basically, if they ask for things that are low feasibility and low impact, that's this square here. Those are things you probably don't want to spend too much time on. However, those high impact and high feasibility items, those are your low hanging fruit, priority one, and you will get some of those when you ask folks. There may be some high feasibility, lower impact items. That should be priority number two. And sometimes those little things, someone says, the printers are always out of paper, or, I can't, the keyboard is not working. You can replace those things. And even though seemingly it's not going to have a huge impact on the healthcare worker's day, it has a double effect by showing that that person has agency and that you listened to them, you heard them and you acted. And of course, closing the communications loop is key. A lot of us who are in leadership, we listen, we take action, but then we never communicate back and say, "Hey, we heard what you needed and we did something about it, and thank you for telling us." So that's the closing of the loop right there. Certainly, and I recognize this is a busy slide, the efficiency of the workplace we know and the electronic health record has contributed to a lot of distress. This is from a paper in which we asked our faculty to indicate the extent to which the electronic health record adds frustration to their day, and we also asked them about their intention to leave. And not surprisingly, the more the EHR was frustrating to them, the more likely they were to leave. Interestingly, or to intend to leave, I should say. Interestingly, the younger they were, the more likely they were. Now, this is some of us were hypothesizing the opposite, based on the idea that the electronic health record tools might be harder for the older generation, so to speak, because of less familiarity with electronic health record tools, perhaps. When there's changes or updates and so forth. But there's also some evidence to suggest that the younger generation is more likely to leave their jobs, or to move jobs, I should say, anyway. So that might be why if they're working somewhere where things are not that efficient, they may say, you know what, I'm out of here. And these are on the left side of your screen are the kinds of frustrations that they spoke to and indicated that were the most time consuming. The in-basket messages and staff messages, forms, and so forth. And again, we asked folks about how much time they spent on clerical work, and not surprisingly, the more time they spent doing clerical work during the day, the more likely they were to burn out. So addressing the efficiencies around, particularly around the electronic tools, the health record and so forth, is a priority that I'm sure many of you in your organizations are already addressing. At Mount Sinai, one of the ways we did this, which was captured in an AMA piece, was through a little pilot grant in our geriatrics group, where they just moved a person's or modified one of their medical assistants' job description to include sorting through in-basket messages prior to sending them to the physician. So we had a system in which every message went straight to the physician. And so by virtue of just modifying this workflow through a small pilot grant that we gave them, they were able to decrease the messages going to the physician by a third. And that had a in a small group, and that had a pretty significant impact on their well-being. Now, of course, there's AI tools that are going to be more and more brought in to address this, and even, as some of you may know, draft some of the responses for the patients that you would just have to look at and edit before sending off to the patient. I'm going to skip over this. It's just another example of one of our pilot grants focusing on an issue on an item regarding prior authorizations. And the point that I wanted to convey here is that sometimes you can have a double or triple benefit if you address a well-being matter. You can also potentially improve quality and productivity or revenue. So it's important to be able to deliver that message. So the last piece I want to speak to is about how organizations can respond and what's happening nationally. I mentioned I'm a chief well-being officer, and every organization is on a journey. So some have chief well-being officers, others don't. It's not so much about that having to be in place in order for well-being to be addressed from the organization. It's really just about enabling the organization to move further along this trajectory, this journey, and committing more to efforts for all the reasons that I've been speaking to you about today. The core functions of a chief wellness officer is something I just wanted to share with you in case you weren't familiar. Certainly at our organization, it's really you'll see a lot here, but I'll move to the next slide to capture it in a little more succinct fashion. Basically, we are the local experts that know how to measure the well-being of all the different groups within an organization, and more importantly, identify what the drivers are that are impacting that. And we like to say that all well-being work is local. And so it's being able to identify the local drivers that are affecting ambulatory physicians are going to be very different than inpatient nurses, pharmacists, folks, doctors that are working in an ambulatory setting or a surgical setting or an inpatient setting. There's going to be lots of different drivers. So we're the ones that know how to measure that and then deliver that information in an actionable format and then drive change. So we have a group of what we call well-being champions. Others call them directors. These are individuals that are embedded in and associated with a given cohort within a large organization who we give data about their people to them and empower them to work with their local leaders to come up with improvement plans that have well-being targets. And to do this on a continuous basis, very much like a continuous quality improvement program. We do some program delivery, so we have coaching programs, for example. But this is a paper I co-authored a couple years ago about what the role of the chief wellness officer is and what it is not. And it's very important to think about the core functions of the chief wellness officer and to keep them within scope, because at some point everything can be a wellness issue. Someone can tell you that they want to have an exercise class at a certain time, or the shuttle bus is not working, or their parking space is, could be better, right? And so there has to be some confines around what the job is and is not. And often it can have to do with the amount of programming that the chief wellness officer is delivering. If the chief wellness officer is the local measurement expert, they can't also be delivering huge amounts of programs, but they do need to partner with folks that can and identify which programs might be the most effective so they can recommend them. But ultimately, the senior leaders of an organization need to act on the recommendations of the chief wellness officer in order to see movement on those outcomes for which the senior leaders are most accountable for, right? So a single chief wellness officer or even a chief wellness officer with a team is going to have no impact on burnout, fulfillment, efficiency of practice, the electronic health records functioning, the behaviors of leaders, without the buy-in and support of senior leadership acting on recommendations. Very much the way a chief financial officer can make suggestions for what are going to be healthy financial objectives, but it's the senior leaders, executive leadership that need to act on those recommendations in order to see those benefits. Increasingly, there's been discussion around how organizations should be held accountable. And I co-authored a piece on this last year, I guess. There's lots of recognition programs. Some of you might be familiar with the AMA's program. The Joint Commission is beginning to look at this from a regulatory standpoint. There's growing discourse on whether there should be public availability of well-being metrics, which is a bit of a dangerous proposition because the factors that are influencing the well-being of the workforce may be outside of the control of the organization. And so if an organization, for example, is in a place that there have suddenly been insurance cuts and they have limited resources to support the workforce, that may have an impact on the workforce's well-being. And yet that organization may have put in place a number of things to prevent to prevent that workforce well-being from getting much worse. And so, for example, having a lot of these programs that I've described to address well-being, the well-being champions, the efficiency measures, the cultural measures, and so that's why it's critically important that we think carefully about how to hold organizations accountable. I would advocate that there are ways organizations can demonstrate that they are really effectively addressing the well-being of the workforce, and that's what's most important. And lastly, who's doing what? CHARM is a professional society for well-being leaders, the Collaborative for Healing and Renewal in Medicine. I have the great fortune to be the inaugural president. We have about 60 chief wellness officers and at least that many leaders in the graduate medical education space. We have people that are experts in coaching and peer support, mental health, workplace redesign, who all come together and exchange best practices, form a community of leaders, collaborate on projects. And it's a great place to be if you're a well-being leader. And we've done a number of things. We hold webinars. We helped write the Charter on Physician Wellbeing, which is part of the AMA's Joy in Medicine Recognition Award. We've written textbooks on how to deliver well-being initiatives in medical school and residency training. And beyond what we're doing through CHARM, there's lots of efforts underway. There's been legislation passed some years ago that led to federal funding. We'll see if that's renewed. The Surgeon General at the time released an advisory supporting health worker attention to health worker well-being. There's the National Academy's National Plan and Consensus Study Report. There's regulatory groups and accrediting bodies that are getting involved. So there's really a lot happening in the national space. This just captures the 7 domains of the National Academy's National Plan for health workforce well-being. And you'll note that most of these focus on the system, on positive work and learning environments and culture, on technology tools, institutionalizing well-being as a value, something that you measure, addressing compliance and policy, mental health, and a diverse workforce. The National Academy is continuing to identify additional priorities and has an opportunity for organizations to get coached on their efforts. So organizations can commit through the National Academy and then receive coaching on how to elevate their organization's attention to well-being. Increasingly and not surprisingly, there's a growing focus on the intersection of artificial intelligence and clinician well-being, and lots of exciting prospects there, and looking to expand the impact internationally. And this is an issue that doesn't just happen in the United States, and increasingly other countries are getting involved and have an interest. And I'd be remiss if I didn't mention the efforts and impact of the American Hospital Association and their Physician Alliance. And this is a blueprint that we created with them a little over a year ago, that outlines a couple of key steps that organizations can take in keeping with the models that I've shared with you, that can help move things along for the organization along a well-being journey that really requires support from the highest levels, taking a strategic approach, as I spoke to, having a sense of accountability and support to do the work, identifying ways to really integrate well-being. It should not just be an add-on, it should be embedded within the fabric of the organization, and having benchmarks to track and measure impact. And so with that, I'm really grateful to have had the opportunity to speak with you today and share some of my thoughts. And I will turn it back over to Rhonda and see if we have time for questions.
Yeah, so I think that we can take at least a few minutes for questions, Jonathan. So lots of great pre-submitted questions, as well as a couple that have come into the chat. So I'm just going to have time to grab a couple. But one question was actually a couple questions came in on this. What impact is the fundamental change from fee-for-service to value-based care having on physician well-being, engagement, retention, et cetera?
Yeah, it's a great question, because at the end of the day, when an organization, we're speaking a lot about how organizations can commit to well-being, but organizations are at one level and they're functioning within the national context, and so the ways in which care models impact how healthcare systems function are going to have huge impacts. So I haven't really seen data that specifically parses out how those changes specifically impact the well-being of the workforce. But I would say that it creates they create a context where there are stressors and headwinds that are going to impact the well-being of the workforce. So if suddenly the payment model changes and that impacts the financial sustainability of an organization, that's going to have an impact on the well-being of the workforce because they're not going to necessarily have access to as many of the support resources that they need to effectively get their job done, right? Interestingly, what I would say is much like what we saw during the COVID pandemic, I would say the way to think about that is changes in payment models that might stress an organization. The workforce is going to the way in which the workforce feels valued, cared for, supported by their organization and their leadership will very likely serve as a buffer. So even in the worst of times with financial stressors, if you feel like you work at a place where they've got your back, they listen to you, they act on what you say, and are there to support you, that's gonna really have a positive impact on your well-being, even in the most difficult of times. I hope that kind of answers your question.
Yeah, that's helpful. Thank you. Another question was, what do you see as the most critical steps to ensuring buy-in and financial support from hospital executives to provide the support needed to create, implement, and sustain wellness initiatives? And beyond financial incentives, are there regulatory incentives as well?
Yeah, great question and really topical. So I would say 10 years ago, we, meaning a group of us who were in positions similar to mine, we would often talk about, okay, what's the argument you need to make the case, quote unquote, make the case to senior level leaders? And it often focused on, we would talk about the moral imperative of a workforce that experienced, burnout and mental health outcomes. We would talk about the financial case, the cost of turnover from physicians leaving or healthcare professionals leaving because they're burnt out. We would talk about the regulatory environment. If you have residents, the ACGME, asks about this stuff. So that was, and to some extent, I believe that case still resonates with leadership. But on the one hand, we've gotten to a phase where I think you'd be hard pressed to find senior leaders that don't recognize, that are not familiar with healthcare well-being as an issue. So we've kind of done good work in elevating attention to it. But now we're at a phase where we need to demonstrate, we need to broaden the ways in which we can show the impact. It's one thing to say there's a correlation between patient experience, quality, turnover, and well-being. It's another thing to say you put this intervention in place and you're going to see X% decrease in burnout and you're going to see, Y% decrease in intention to leave. So I think that's the phase we're at. And there's some, emerging data that can do that. But now I think our leaders are savvy enough to know that this is an issue. Now they want to say, okay, show me the evidence for, the way in which I commit to this and how it's going to have impact. Rhonda, there was a second part of your question, not just financial, but
if beyond financial incentives, are there regulatory incentives?
Yeah. So the ACGME, when it comes to residents, has been at this the longest. The Joint Commission has been asking about this, but hasn't, to the best of my knowledge, mandated any particular requirements. The LCME for medical students. So a lot of the regulatory and accrediting bodies have gotten on board with this. What we haven't seen yet is sort of like what does it mean for hospitals? How is it gonna, we know what it means for residency training programs. They can have warnings and such if they're not, paying attention to this. We haven't seen what it's going to mean as of yet in terms of a regulatory environment that sort of incentivizes or disincentivizes healthcare systems for paying attention to this. This is the thorny piece I was speaking to. Part of the problem is there's many different ways to measure well-being, many different outcomes, And you can have a place that is functioning and that's doing great work to promote the well-being of its workforce and may have higher levels of burnout than a place that doesn't care about it at all. And and you don't want to sort of discredit that place that's doing really great work even further because of their levels of burnout. It could be that the context that they're doing their work in, things like we were talking about, the payer models and so forth, are what's driving that. And yet the place is doing as best they can, if not better. So that's where it gets thorny when you start saying, well, we're gonna put regulation in place, and any hospital that has under 40%, has more than 40% burnout or some measure, we're gonna ding them in some way. It's really problematic. And I think what's more important is that we identify the ways that are evidence-based, that we know support the well-being of the workforce, and advocate that institutions demonstrate how they are committing to implementing those kinds of interventions.
Yeah, thanks. I've had about 3 questions come in on this, so I know we only
Please.
have a few minutes, but I want to at least give you, 60 to
Yeah.
90 seconds to weigh in.
Great.
What impact are physician compensation plans on wellness? And there was, what impact is physician incentive compensation having on engagement, burnout, retention, overall satisfaction? So several questions came in about, okay, compensation, how does this actually come into play?
Yeah, I would say, so money matters, and it will have an impact. And when we ask on our faculty surveys, like, what's something, we give them a list of things that might improve their well-being, certain, increased compensation plans and so forth it's always, high, but it's not the only thing that's high, right? And actually, feeling recognized and appreciated for a job well done is usually right up there. And so the way I put it all together is, money, your compensation is one way of showing love and showing that we care about you. It's demonstrating that there's value that you bring, right? So it is a real way to say, remember I was saying, it's not just saying thank you, it's showing, right? So the way you pay someone is a way of showing how you care for them. But there's other ways of doing that. And I would argue that people who work at organizations that are really good at making you feel cared, valued, respected, and enable you to do their work may be more inclined to stay there, even if they get a salary bump, and an organization which doesn't really seem to, value that to the same extent, doesn't listen to you, doesn't, try to improve the way that you're experiencing the workplace. So it's important, it's a way of demonstrating care and value, but it's not the only thing. And sometimes, especially sometimes the CFOs they just think that way in terms of, oh, we just, the reason these people are leaving is because we're not paying enough. We gotta bump their salaries. And it's just not that simple.
Yeah, a complex issue for sure. Thank you, Jonathan. This has been a super enlightening conversation today. Wish we had more time, but do need to just quickly let everyone know that if they could please complete the evaluation form that's going to appear on your screen once the webinar ends. When we close out the webinar, the screen will pop up with the link for the evaluation. So please do fill that out. Again, if you want continuing education for your time today, you'll want to create that Duke OneLink account and then text that code onto this that's on the screen to that number that you also see on the screen. So thank you everyone for joining us. Don't hesitate to reach out to AHA Team Training if you want us to connect you to further resources, have further questions for Dr. Rip. We'll pull on his shirt tail for you. So, all right. Thank you, everyone. Have a great day.